Yeah, I would like to invite Dr. Roy Kiberench. He'll be going to speak on artifacts and pitfalls. He's an assistant professor in cardiac thoracic anesthesiology at the University of Minnesota.
Hello, good morning. Thank you very much for this opportunity. And I'll be talking about echo artifacts. We'll start off talking about how the images are formed in ultrasound. We'll go from there and talk about and then we'll proceed to talk about the assumptions that are made by the ultrasound machine as it's converting the beams that it receives into the images. And then we'll talk about the different types of artifacts that are formed when those assumptions are broken. And then we'll go over a short case just as a review of the information that we just learned. So as far as image formation is concerned, so the ultrasound is formed, initially starts off as with piezoelectric crystals. So these are crystals that convert one form of energy to another form of energy. In this case, it converts electrical energy into sound. The sound is then transmitted through tissues, mostly at a velocity of 1540 meters per second, and then through air at 330 meters per second. When this sound beams then hit an interface between two media, they either reflected back or they're transmitted through to the next media. And this all depends on the acoustic impedance between the two media. Acoustic impedance is mostly determined by propagation velocity and the density of the media. And there's not that much difference between one media or the other as far as propagation velocity is concerned. So most of the differences in acoustic impedance are usually due to density. Like I said, when those sound waves are then transmitted back to the transducer then takes those and plots them on the image on the screen. And and the depth is determined by the distance it took for the beams to go and get reflected back to the transducer, and the brightness on the screen is determined by the intensity of the waves that come back to the transducer. So these are the assumptions that the transducer makes while it's taking the sound waves that are reflected back to it and forming an image. So just to quickly go over it, it assumes that the echo images go once and they're reflected back up before they get back to the transducer. It assumes that the waves are infinitely thin and the pulses are really small, pretty much assuming that the resolution is really good. It also assumes that most of the energy comes from the main beam and there are no side lobes as such. This makes an assumption about the speed of transmission, and then it also makes an assumption about the attenuation as it goes through tissues. And as you can see on the right of the screen, when those assumptions are broken, those are the different kind of artifacts that we have that result from that. So the first artifact that we have, which is probably the most common, is acoustic shadowing. So this occurs when you have a very strong reflector, and there's a big difference in acoustic impedance between two media. In this case, the sound waves come, they hit the reflector, and they're essentially all reflected back, and there's very minimal transmission through it. As a result of this, you have there being shadowing deep to the reflectors, and there's not much that you can image deep to the reflector. So this not only applies to 2D images, but it also applies to color Doppler as well. And this becomes a problem when you're assessing for regurgitation, as we'll see in the case at the end of the presentation. So most commonly you see this usually in transesophageal echo from mitral valve rings or prosthetic mitral valves, pacemaker leads, that kind of thing. And as you can see in this image, this patient has bileaflet mechanical mitral valve, and that's causing a lot of acoustic shadowing, and you can't really see the walls of the LV very well. So this is a video clip showing acoustic shadowing. In this case, you have a commissural view. You have a patient who has significant calcification of the mitral valve leaflets, and that's essentially shadowing out the entire left ventricle there. This is another clip. And as you can see here, the acoustic shadowing is actually forming more of a problem because if you wanted to actually assess what's going on with the inferior wall of the left ventricle there, you really can't see it. So as you can see what this does, then it looks at other images, transgastric short and a transgastric two chamber to actually look at the inferior wall of the left ventricle. So, sorry, okay. And then the next artifact that we talk about is enhancement artifact. So, like I said, one of the assumptions that the machine makes is that the sound waves that are attenuated equally as they go deeper into the tissues. When that assumption is broken, for example, when you have some waves that are attenuated less than other waves, you have this enhancement artifact. So if you look at this image, which is a transgastric short, there's more attenuation in the sound beams that go along the septal and along the lateral walls. So the areas deep to that tend to be not as bright as the areas in the middle, which pass as the sound wave passes through the less attenuating cavity of the left ventricle. So what you end up here is with a very, very bright anterolateral papillary muscle and not as bright posterior medial papillary muscle. Next, we have reverberation artifact. This can be formed a variety of different ways. As you can see here, if we go with the image on probe A, so probe A is a situation where you have two reflectors that are pretty close to each other. And what happens in that case is the ultrasound beam, as it's reflecting off the deeper, reflector going towards the transducer, hits the shallower reflector and keeps getting bounced back between the two reflectors. And what you end up is a stepwise image with equally spaced, what look like ladders on rungs on a ladder. If you look at probe B and probe C, those are the different ways that we can form ring down or comet tail artifacts. And those are formed when you have like air bubbles in a fluid, and they can either reflect the sound waves or they can resonate those. This is an animation that shows a different way that you can have a reverberation artifact with only one strong reflector. So in this case, you have one strong reflector. When the sound wave is reflected back to the transducer reflects it back to the reflector, and you end up with that structure being portrayed multiple times. As you can see there, that's the first one, and then there'll be a second one formed when the sound wave is reflected again. Okay. Mirror artifact occurs when you have a strong reflector that is not perpendicular to the main ultrasound beam, and you have an object that is kind of lateral to that strong reflector and shallow to the reflector. So what you have in this case is you have a beam that goes down to the strong reflector, is reflected back to the object. That is then reflected back to the strong reflector and back to the transducer. The transducer in this case looks at it and thinks that it's an image coming from straight down the main ultrasound beam, and the image that is then formed is deep to the original image and lateral to the original image on the other side of the strong reflector. So this is a good example here. Here you have the pericardium acting as a strong reflector. You have the mitral valve apparatus that you can see there. And if you look deep to that, essentially outside of the heart, you'll see what looks like a reflection of the mitral valve leaflets as well. And in this case, that's really must be artifact because that's completely outside of the heart. Okay. And then refraction is the other thing that can happen when the sound wave hits an interface between two media that have different velocities. So the sound wave will come, hit the interface, and then will bend, the beam will bend, and that's what's called refraction. The refraction follows Snell's law, which states that the ratio between the sine of the incident angle and the refracted angle is equal to the ratio between the velocity in the first media and the second media. This is an animation showing how refraction occurs, and you can see if the lens is an interface between two media, then what you have is a beam that comes down, is bent over, can hit an object, and it's then interpreted by the ultrasound images coming from the main beam, kind of straight down and deep past the interface between the two media. So sidelobe artifact is another kind of artifact that we have. Do you have the pointer? Sorry. And this one might be a little confusing, but what happens is that the ultrasound assumes that the ultrasound beam, all the energy goes through the main ultrasound beam. But the beams there are usually some side beams that are weaker, but when those side beams encounter a very strong reflector, they're able to be reflected back and actually detected by the transducer as coming from a structure. But the problem with this is that when these beams from the side lobes are taken back to the transducer, they're assumed to be coming from the main ultrasound beam. So this is an image that kind of illustrates that. Here we have the beam that's coming from the left side and scanning over towards the right side. And you have two structures here, the green structure and the red structure. So when you start off here, there's nothing that's being that the main beam is, that's reflecting off the main beam. The only reflection that's coming off is from the green structure here, and that's reflecting a side lobe beam. So what happens is, in this case, this reflects back the transducer. The transducer assumes that the reflection's coming from this main beam here, and it plots the green structure right there. And as this scans over, you have now a situation where you have the side lobe here reflecting back an image, which then gets plotted here, and the main beam here reflecting off this green structure here, and those get plotted, kind of superimposed on each other. As this beam continues moving along, you have a situation where now the green structure is reflecting off a side lobe, and the red structure here is reflecting off the main lobe, but they're both interpreted as coming off the main beam here, and they're all superimposed on each other. So if you have a large reflector, in this case, you may end up having something that's a radial arc all the way across the image, as we'll see here in this animation. So here you see the situation where the main beam is kind of scanning along, and you end up having multiple images, even though you have only one structure. And this video clip illustrates how you can have, so the pericardium here is acting as a reflector, and it's creating a side lobe artifact here. And you can see there's an arc all the way here from one side to the other side of the image. I'll point out here, we'll see This right here, this clutter, that's called near field clutter, which we'll talk about next. And here you can see the mirror image here. And here there's a lot of comet tail ring down artifact here as well. So beam width artifact. So there are three different types of spatial resolution. There's a lateral resolution, longitudinal resolution, and an elevational resolution. Elevational resolution is the poorest in ultrasound. And in this case, if we look at this image here, we have two objects that are beside each other in the y-axis. Okay. So the ultrasound assumes that the beam that is sent is infinitely thin, and it could detect the difference between the two structures, the blue one and the green one there. Now, if these structures are closer to each other than the actual elevation resolution of the ultrasound beam, then what you end up is with these objects being placed kind of superimposed on the same plane. This can be a problem if you imagine if you're doing like a parasternal long on TTE, you might be able to see something like color from the tricuspid valve on the right side being superimposed when you're looking at structures on the left side. So beam width artifact also would apply to the x-axis. So in this case, lateral resolution becomes the issue. Lateral resolution is also known as angular, transverse, or azimuthal resolution. This is best at the focal zone, and that's why we have a focus on the ultrasound machine, where we can take it up and down depending on the area of focus, the area that we're trying to look at. So here, if you can see, the focal zone is way up here at the transducer, but the area of interest is probably here because you're trying to investigate the left atrial appendage. And when this focus is up here, the lateral resolution is best here and is poorer down here as the wave kind of diverges out. So what you end up with here is, if you look here, you might think that there's something in kind of the mouth of the left atrial appendage. But when you bring the focus down to exactly the area that you want to image appropriately, you see that these are two distinct structures and there's nothing actually in between them. So that's an improvement in the lateral resolution at that point. Okay. So near field clutter is the last kind of artifact that we'll look at. And this is as a result of the high amplitude oscillations of the piezoelectric crystal, which forms a near field artifact close to the transducer. And in this case, what you end up with is a lot of noise here, very close to the transducer. So in transesophageal echo, you see this mostly when you're looking at the aorta. And in this apical 4-chamber TTE, it looks like there's something here in the left ventricular apex. But if you look at it more closely, you actually see that there's no, that whatever it looks like is in the left ventricular apex really doesn't move along with the movement of the heart. So that really must be near field clutter. Okay, so we'll end up with the case. So this is a presentation. This is a patient that was taken care of in our hospital in the last few weeks. So this is a 58-year-old man who came for a mitral valve replacement via right thoracotomy. He had a history of mitral regurgitation. He had undergone a mitral clip, but that hadn't relieved his mitral regurgitation, so he came in for a mitral valve replacement. He'd had a history of coronary artery disease. He was status post bypass, 3-vessel bypass about 2 years prior. He had ischemic cardiomyopathy with an EF of about 15 to 20%, and he had had an AICD placed as well. He had atrial fibrillation and some pulmonary hypertension. So pre-bypass, we got some clips here, and what you can see here is a lot of acoustic shadowing due to the calcification of the mitral valve. And as you can see here, if you were trying to kind of evaluate the walls of the left ventricle, that would be pretty difficult to do. So we cannulate this through the femoral vein and bring the cannula all the way up to the SVC. So, and this is a bicaval view, a mid-esophageal bicaval view where we're trying to assess the position of the cannula. And as you can see, here it looks like you actually have multiple cannulas in the right atrium, which this is then a reverberation artifact. So the patient did then receive a bioprosthetic mitral valve replacement. And as you can see in this image, there's a lot of acoustic shadowing from that, and you really can't assess the left ventricular walls at all. Like we said earlier, this acoustic shadowing not only applies to 2D imaging, but it also applies to color Doppler. So when they were trying to assess, the for color in the long axis view here, you can see that if you were trying to look at aortic regurgitation here, there's really not much that you can see on the LVOT side of the aortic valve. So that becomes a problem with the acoustic shadowing when you're trying to look at something like that. So what you do in this case is then you go and get transgastric views where your sound waves your sound beams don't have to pass through the mitral valve before they get to something else that you want to look at. So in this case, you get a transgastric 2 chamber, and you can see the inferior wall there and the anterior wall pretty well. These are my references. Thank you very much.